everybody. Welcome to the Babies in Common Videocast podcast. We hope today's going to be a great conversation with your help as well, those of you who are on the call live. And I'm Jeanette Messit from the owner of Babies in Common. I'm an internationally board certified lactation consultant, childbirth educator, mostly retired birth doula. I have a public health background as well, and I have 2 teenagers. And Melissa is joining me as always, as this is our group project. We're just saying it's our quarantine project, although we hope we're going to continue it after we're allowed out of our
see where it brings us.
Yeah.
The world is our oyster. So thank you, Jeanette. I am Melissa Ann Dubois, and I am a registered nurse, childbirth educator, and lactation counselor practicing in Massachusetts. I've worked in all sorts of settings, inpatient, outpatient, high risk, low risk, and I currently work as an LDRP nurse at a community hospital in Massachusetts. I'm also the mom of 3 small children, and I help lead groups sometimes and teach classes with Jeanette at Babies in Common. So we have another great episode for you guys today. This is very exciting. But before we get started, again, just a couple reminders. First, as always, anything that Jeanette or I say during this conversation is not to be taken as medical advice. And the opinions expressed during this conversation are personal to the hosts and guests and do not ever represent the views or policies of any current or former employer, including hospitals and clinicians. So for a full review of our disclaimer, please visit babiesincommon.com/disclaimer. And second, this video cast is interactive. If you'd like to ask a question, you can hit your clapping emoji reaction at the bottom of your Zoom screen, or you can simply wave your jazz hands at us and we will pause. Jeanette's doing a little clapping emoji now. And you could also type in the chat box, whatever you would like. We'd love to see your smiling faces as well. And that's it. Back to you, Jeanette.
All right. So today is April 20th, 2020, and today we're going to be talking about choices in childbirth. And we have asked our dear friend and legendary midwife and doula extraordinaire in our area, Joyce Kimball. She's a seasoned home birth midwife currently practicing in central Massachusetts, and she's an experienced birth doula, childbirth educator, home care nurse, and advocate for families. She's also president of the Massachusetts Midwives Alliance and has 2 children. And today we wanted to discuss your legal and human rights related to pregnancy, birth, and parenting, which is a huge topic for anyone who is or one day may be pregnant, but also just extrapolating anything we say here today to any time that you or any of your children are receiving any medical care at all, or considering receiving it, making informed choices and informed decisions, and we'll talk even more about that. So thanks for joining us today, Joyce.
You're welcome. I should add to the list, Melissa, when you said anything that Jeanette or I say should not be construed as medical advice. Anything I say should not be construed as medical advice. Anything that I opine on is my opinion and my opinion only, and not those of my employers or clients.
Right.
Excellent. Yes. Please consult your own qualified healthcare provider.
Whoever you want.
I would love to start the conversation off today with a short passage from a book that I'm currently reading. Actually, Joyce, you were the one that got this into my life. It's called Give Birth Like a Feminist, Your Body, Your Baby, Your Choices by Millie Hill. And yeah, we were just talking before we started about how many things we've flagged and highlighted. I'm only partway in and I love it. So this passage, I think, is totally on theme with what we're going to be discussing today. So the author starts chapter 1 by describing her first birth experience. And she writes, "They did not let me. I was not allowed. I have had to have. I wanted but." You would think these phrases would be confined to the history books. And yet they were to become part of the fabric of my own first daughter's birth story. I have given this phenomenon its own special name, the language of permission. Quote, "I began to wonder how these phrases trip so readily off the tongues of 21st century women. We would not accept being restricted in this way in our relationships or marriages, in our educational choices or our career paths. Why, then, when it came to giving birth, were we using such passive language, casting ourselves as permission seekers rather than permission givers?" So I hear these things a lot in childbirth class, in my work as a labor and delivery nurse, in my conversations with clients and patients and friends and family in and out of my professional setting. They did not let me right? I wasn't allowed to. I had to have. I wanted to, but. So what do you guys think about that? Has anybody here on the call had similar experiences in their own labor, pregnancy, birth? Has anybody found themselves saying those things when describing any of their experiences? I'm seeing nodding heads.
Hi, my name's Karen. I am currently a student taking childbirth educator, infant massage educator, labor doula, postpartum doula, the whole gamut.
Awesome.
I don't have any kids of my own. The only thing I can speak to is that I've been dealing with lots of medical issues since I was a child. And since I was 16, 17, 18 years old, I learned very early to take control of my own health. And I've called out several doctors, and told them that they can't talk to me a certain way, or, I actually called out one particular doctor in front of the transplant director.
That is amazing.
Because he thought I was purposefully, because a little backstory, my first kidney transplant rejected because of too much cyclosporine toxicity. And second time around, was talking to my doctor, and we were thinking about reducing my cyclosporine because of that issue. And intern came in, my one particular
You're breaking up, Karen.
I told him, oh, no, so you.
Oh, Karen,
I'm like,
breaking up.
and I've known him since I was 17 years old. Huh?
You were breaking up there for a minute, but go ahead.
Oh, sorry. Yeah, I told him to go get my doctor, because I'd known him since I was 17 years old, and he came in, said hello to him, asked him how his wife, kids, grandkids are, and I told him exactly what the doctor said. And he's like, really? Looked at the doctor, looked at my numbers. He's like, you know what, Karen? He goes, your numbers look great. He goes, won't we wait another 6 months when I see you, and we'll talk then? I said, okay. He left. Doctor was livid. Couldn't believe I did that. And I'm like, you know what? I says, you're just doing your rotation. I said, I'm not just a number. I'm not just a name on a chart. This is not my first rodeo. I said, I probably know more about my body than you do.
Well, that's a really good point. I'm glad you actually brought this up, Karen. And yeah, we're all giving, for those who can't see on the podcast, we're raising the roof around here. I love that you started us off actually not even talking about childbirth and pregnancy, because there are so many people that would feel comfortable maybe advocating for themselves in a variety of other settings in the hospital or outpatient. They're oncologists accepting or declining medical treatment, even life-saving medical treatment, with their primary care provider, switching a primary care provider if they're not, working up your concerns or treating your ailments or chronic illnesses the way that you want. The list goes on, right? If you've had to have some major surgery, people shop around before they get their heart valves replaced, or gets that stent placed for their cardiac issue. And yet in the world of pregnancy, labor, and birth, so many of us who might have spoken up for family members or ourselves in other settings don't in that field. And that's very interesting. Why is that? Let's start by talking a little bit about what informed choice and informed consent actually is, and what is shared decision making, which is the model that American College of OBGYNs, ACOG, midwifery organizations, nursing organizations, and other medical organizations in other specialties are globally talking about is the best way to provide care. Joyce, would you mind talking a little bit about, as a midwifery provider, so you are a provider of care, what informed choice, informed consent, and shared decision-making looks like to you?
Yes, I will do that. But before I forget, I'm really glad that Karen brought up how people make decisions about their care in a non-birth setting. And maybe we can talk about pregnancy, labor, birth, and postpartum as 3 separate sections, because what you're like in pregnancy and the interactions that you're having with your care providers in pregnancy are different than your state of mind and who you're interacting and how you're interacting in birth.
That's very true.
Yeah. So yes. I don't have a definition for informed consent. I'm sure I should have one.
No, what does it mean to you as a provider?
Well, you know what? I should catch myself. I shouldn't be saying informed consent, because that implies that I'm trying to coerce or get someone to consent to what I would like them to do. So it really should be informed choice. It should not, the words should not be informed consent. And, you know, we use informed consent language all the time on our informed consent documents. And it really should be informed choice, or I'm old, so shared decision making is a new term for me. But I like shared decision making. I'm old.
Well, that's a good point, because informed consent, like you said, it's a buzzword, but it is implying that the patient will be given risks and benefits, but then will consent. So when you say informed choice, that actually brings in that a patient, a client, the patient can either consent or decline. Right. And I prefer the word decline and not refuse, because refuse, I hear that a lot. Oh, she's refusing prophylaxis for GBS, or she's refusing an IV. No, she is declining those things, which is her right to do, because every single hospital in this country and every major medical and midwifery organization, if you look up your patient bill of rights, is allowing for patients, clients to reject medical advice if they want, you know.
Even if it kills you or your baby.
Yes, exactly.
I know that sounds life-saving treatment, but that's what women get told. You must agree to this, or it will kill you or your baby, and that's not allowed in our society. So, all right.
I wanted to add one more thing with what Karen was saying and what Melissa was saying, is that I feel like over the years, what I hear a lot of people saying related to who they're choosing just for their pregnancy and birth care is, I don't know, my friend said that they like their doctor or their midwife. And so you're choosing them based on like one person's recommendation, or maybe it's 3, but you're not choosing them based on, I went and met with them and I talked to them about what my desires are. You're not even usually talking about your birth desires until very, very, very late in the process. So it's really not shared decision making or even informed choice, because you don't really have a choice if you don't know what the choices are. And we do a lot more, like Melissa said, research on who would do something else for us medically, or even how to buy a camera or which TV to buy. And we're just like, I don't know, they're nice. Or my GYN provider has always been this person. And so now that I'm pregnant, I guess I'll just stay with them because they're nice enough. And that's not a really good idea to do. They could be fantastic, but maybe they're not. Joyce?
I'm going to push back a little bit, because that makes the birthing person responsible for who she or he or they see. And in our country, the way we've set it up, because we have 4 million babies born every year, we have this massive institution that catches 4 million babies every year. So we ask all kinds of people, all kinds of advice, and we're at a loss for who to go, where to go. And we don't talk about birth, and we certainly don't talk about, you know, death and choice. But she may have, or the birthing person may create an amazing relationship with the care provider and never see that person again. So we are asking the birthing person to find amazing care, have all these deep relationship building times with that care provider, knowing, it feels like a setup, knowing that that birthing person may never see that person and is going to interact with huge sums of people that they have no relationship with at all. So yes, it is good to see people prenatally that you can develop a relationship with, but like, to what end? Does that contribute to us women feeling like the rug got pulled out from underneath them when they walk in to the hospital in labor and they never see the person that they've developed a relationship with?
True, right.
Anyway.
It is definitely an unfortunate reality.
That's not their fault. That's
It's
not
not
their
their
fault.
fault.
That's our
It is the-
system.
It is the reality though, right? So we have some amount of choice in that. So, one bit of advice that I give as a childbirth educator, and I see you, Catherine, calling on you next, is, don't just pick somebody that was recommended to you unless you ask why. Again, that doesn't solve the problem of maybe never seeing them on labor and delivery. I learned that I asked some coworkers, who would you go to for a chiropractor? And someone said, oh my God, you absolutely have to go to Dr. X. He is amazing. Everything is so great. You've got to go to Dr. X's practice. So I said, okay. So I signed up and it was awful. It was the most horrible. He had the most horrible bedside manner. His office was creepy. This is in New York. It was painful. It was the most painful chiropractic adjustments I'd ever had. So I went back to her and I said, why did you recommend this guy? He's like kind of a jerk. Like and she said, oh my God, the lady that makes the appointments is the sweetest and they have the best coffee in the office. I'm not exaggerating. Like this is what, and I was like, I probably should have asked why they like this person, right? Because some providers, they'll get a good recommendation, especially from a mom or birthing person who's had many children before, and they like that person because their appointments are quick, right? And they're always on time. And that's important to that pregnant person because they have kids to get to. They don't have a lot of questions and they want to be in and out. Whereas that might not be a first-time parent, right? Catherine, what's your question?
It's more of a comment on what, Melissa, you're saying and what Jeanette's saying, which is that's exactly what I did with my OBGYN. Was I got a referral from somebody. I went to see her. I discussed my birth plan with her, which I spent a lot of time on, but I was newly pregnant. And her response was, I think the first time I wanted to talk to her about my birth plan, I actually think she laughed out loud. And which should have been an indication right then, find somebody else. And I didn't, and I stuck with her. And every time I would go in and see her, I'd say, so at what appointment are we going to start talking about my birth plan? And I think she pushed it off until 35 or 36 weeks, at which point I felt like it was too late to go find somebody else. But I mean, I'd love to talk about this today, how to find, well, actually, if I ever get pregnant again, I'm hoping Joyce will be my midwife, but I mean, for people, how to find an OBGYN or a midwife, how to advocate for yourself, because I really felt like I wasn't able to advocate for myself during my pregnancy. And this is shocking because I feel like I advocate for myself all the time. What was it about being pregnant that changed for me?
I love that. Joyce, that kind of leads to what you were saying about, let's talk about being pregnant is different than being in labor and then postpartum. Can you speak a little bit to that? What you've seen as a doula or a midwife, a birthing person yourself? Like, why is it that so many of us advocate strongly in other areas but find ourselves unable to advocate or afraid or don't have a voice to advocate in situations surrounding labor and pregnancy and birth?
People are taught not to trust their feelings. People are taught to suck it up. People are taught to assume that it was them and not the other person. Particularly women, it's tend and befriend, and it must have been me. And I mean, I believe we are groomed from womb to behave a certain way. And I think during pregnancy, we are groomed in fear. Like it's massive authority and knowledge that supersedes any personal knowing at all. So I think it's cultural and societal and psychological. I often say, if you are leaving your appointments crying, don't go back. And that's news to people. Like, they're like, oh, really? Like, I don't have to go back because it either physically, emotionally, or mentally hurt? No, you don't. People feel trapped in their choices. Our insurance system and finding another provider is such a pain in the neck. Everybody has cutoffs and copies of records, and it just feels like a hassle. Everything feels like a hassle. So, I think it's societally groomed. I think we've elevated this. People have a body of knowledge that have white coats on, that know more about your body than you know. And it's just, people don't know that they can change at any time, because our culture is suck it up, pull yourself up by your bootstraps, bear through it, it'll be over soon. You know, I mean, yeah.
I agree. I think there's also, this narrative in our culture that all that matters is a healthy baby. And we hear that from very young age. And so nobody would ever want to do anything that could feel or be perceived as possibly putting their baby into harm's way. I also think, and I'm guilty of this 100%, I had a crack in my bathtub, a very hairline crack that I knew was there, that I just chose to ignore because I was hopeful that it wasn't causing the damage that I knew it could possibly cause, right? Like because nothing was leaking out under the tub and the tiles were all still in place. Like, I'm not joking. This went on for years. I knew there was a crack around the drain. And my Facebook reminded me that 2 years ago today, we had to tear down the walls of my bathroom and repair the incredible amount of wet rot that had formed behind there, because I was just hoping it would all work out. And I'm telling you this because that is ridiculous of me, right? Like, I knew there was a leak in my bathtub. I know what water does to wood. I knew this would cost me thousands of dollars if I didn't do anything about it. But I also knew that maybe if I didn't look behind the walls, I didn't have to deal with it right now. And I feel like a lot of birthing people, pregnant people, they have these red flags, but there's a lot of other things going on in their life. And they know some people who have had good experiences with that doctor or at that hospital. And so they're like, I'm going to think positive, and it's probably just going to work out for me too. And only after it doesn't work out are they kicking themselves. And then they call a doula, or they could take childbirth class, or they, whatnot. And I think that that's a part of it too, is just not wanting to deal with it, right? We talked in our second episode, breaking up is hard to do. People feeling worried about breaking up with a provider, right? So I think that's part of it as well.
Nikki,
what about you,
Nikki just made a comment. I also think there's a sense among some people that other people's stories won't happen to me, quote, as though they're somehow exempt from the statistics and culture and practice.
Mm-hmm.
Yep.
And so what I like to remind my patients in my childbirth class, my clients that take my class, I like to say, you only get to give birth to this baby one time, right? So even if you go on to have 22 quiverful of children, you only get to give birth to this baby one time. And the way you give birth to this baby can impact your physical, emotional, and mental health for the rest of your life. That sounds really dramatic, right? But I say it so dramatically because it is so very true. It is so very true for, us in the biz who see it time and time and again. Karen, you had raised your hand. Do you have a comment or question?
Yeah, I just wanted to kind of piggyback on a little bit of what Joyce had said, that, in at least in my experience, I can speak for both my mother and father, and my father was a huge advocate for me when I was younger, because I didn't know how to advocate for myself. When he ended up with colon cancer and he was on chemo and all sorts of drugs and things like that, I would say, okay, well, did you talk to the doctor about this? Oh, no. If it was an issue, they would have told me. I'm like, no, you question everything. And I think so many people that go to see doctors are like, they get the white coats, they get the PhDs, they should know everything. And it's like, no, they don't know everything.
I would love to piggyback on that about partners. First, I want to get into the weeds and let's talk about informed choice in pregnancy, specifically, just as, for examples, the glucose tolerance test and the Group B strep test, because those are really hot buttons. And
well, before you do that, Joyce, let me give let me give that definition of informed choice.
Oh, sorry.
So
Yeah.
that is when that's fine. That is when a person is given options to choose from several medical interventions, tests, or procedures, knowing the details, benefits, risks, and expected outcomes of each. Right. So, and shared decision making is a key component of patient-centered healthcare. It's a process where clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risks and expected outcomes with the patient's preferences and values. So, two things that you're talking about that are a matter of routine is Group B strep screening at around 36, 37 weeks, and the glucose tolerance test sometime between 24 to 32 weeks. So have at it.
Well, using it as an example, right, of informed choice. So it's routine standard care. Very little communication happens. Most people don't know that they have a choice. And what ends up happening is people that want dialogue and options feel like they need to convince their authority figure of their choice, right? So we're already in a power differential situation, right? We have this is how we've always done it. This is how we do it. Your baby could die. Your baby could get big. Your baby could have shoulder dystocia, right? So we do all this fear mongering. We have a power differential. And then we ask this person that we've groomed through their life and through this pregnancy to be afraid and to look to this authority figure. And we ask that person, well, why would you not want to do this thing that could save your baby's life? Like, that could give us information. And we ask that person to convince the authority figure why they could ever possibly do something that is against medical advice. This is how we've done it. So we spend all of pregnancy like trying to reconcile what we want versus what the norms and cultural standards are within our institutions and our authority figures. So how does one navigate informed choice during pregnancy if they desire something that's outside the standard? Like, I can't prevent a provider from saying your baby could die. Yes, childbirth educators, do you role play? Do you practice? I know some providers don't like it when birthing parents bring studies that support their decision making. They feel, put upon and, really arrogant about it. So what's the best way to handle a disagreement in care during pregnancy, given the power structure and everybody's personality?
Yeah, well, I think that's a very good question. And one of my questions was to talk about red flags of providers that that do not practice a shared decision-making model of care and informed choice. Before we do that, though, Joyce, how would you have had that conversation? Because as a midwife, you is that a service that you offer or can refer people for that want it, the Group B strep screening, for example, or glucose tolerance test? Yes. Okay.
Yes. Yep.
She's nodding her head for those.
Yes. Yes.
So can you role play with us how you would approach that conversation, for example, with your clients, so that people can hear what that would sound like? Because one of the questions I got just typed into the chat box was, wait, are we allowed to decline those tests? And there's that permission again. Right? I see you. There's that language of permission again. So how would you have approached it?
So I let people know around mid-pregnancy that the standard care in pregnancy is to do something called a glucose tolerance test. I have a whole 4-page informed choice document. There, these people might be at risk. This is the sequela of events that might happen if you have gestational diabetes. And here are ways that we test people's blood sugar. And there are options and choices. And not taking the test is an option. And then there's monitoring, and there's monitoring for different lengths of time. And there's doing the glucola versus doing, there's this whole, it's a dialogue. It's a full conversation. And I have no more power over her choice or their choice. it is their choice, 100% entirely. And how delightful for me that I've had people select evenly between the 4 choices, so that it is not unusual for me to have a client that chooses to drink the glucola, and clients who choose to decline the test, and clients. So it is not unusual for me. I have no skin in the game. This is not my body. This is not my choice. I am here to provide information, and yeah. So yeah, it's a dialogue, and it's a dialogue before 28 weeks. The other thing that comes up with the gestational diabetes screen is retaliatory care. Like, if you're not going to drink the glucola, which is what I want you to do, I'm going to make you test your blood sugars 4 times a day for 2 weeks. And as a care provider, I know that that is complete overkill, 100%. It pains me to watch people make choices and get a little bit punished for it. Anyway, that's my gestational diabetes screen spiel.
And Aslan, what's your question? Ashlyn?
No, I just wanted to say I'm 33 weeks pregnant, and I just went through this with my OB.
Congratulations.
Thanks, like maybe 5 or 6 weeks ago. And I knew I wanted to do the test. This is my 2nd pregnancy. And the conversation went like this. Okay, do you have any other questions? No. Oh, looks like next week you're going to have your glucose test. They'll give you the bottle when you get to the front. And I was just sitting there like, okay, well, can we have that conversation now? Because I know I want to do it, but you actually haven't even talked to me about it. So just as an example of like the complete difference, it was almost like, okay, we're done with our appointment. Let me just add this at the tail end. So it's
the assumption of compliance.
Yes.
Yeah.
And I mean, there's a lot of good research backing up the importance of screening people for gestational diabetes, right? So I'm not minimizing that as an OB nurse. Gestational diabetes can have serious consequences when untreated for mothers and babies. It still should be a conversation. That's and what I find, and I try to get through to providers that I've worked with in the past, is if we have an informed choice conversation with people, in my experience, 99% of the time, they go with what your recommendation is anyway. But they feel more empowered. They feel like they were part of the decision making. They felt like they could ask questions. They felt like they were truly informed. Because at the end of the day, they did hire you to be their provider because they trusted you to some degree. So why are you afraid to give people information? Like, so it isn't particularly frustrating because, even people like you, so I was planning on having it anyway, but it still would have been nice to have it be a conversation instead of just a knee-jerk automatic. Nikki is raising her hand.
Yeah, it almost made it more of a negative because I was like, you're not even respecting me enough to have this conversation,
I think it's like power dynamics 101 and human psychology. Like, not one human being from birth through death wants to be told what to do. And I mean, you can get someone to do whatever the hell you want if you know how to word it right anyway. So it's almost like such a lost skill. Even if someone was super dedicated to being like, my patients are all going to do this thing that I feel everyone has to do, there's still a way that it gets presented where they actually have their own desire. But in the most ideal world, as you said, Melissa, most people are going to choose the standard of care because there is a fair amount of evidence for good standard of care. But like I said, not one human being alive is like, please tell me what to do and I will just follow like a little sheep. It's not how humans work. So there's clearly a huge skill set lacking, or a time constraint that doesn't allow for the nuance of a conversation, or some power struggles. Could be a lot of things.
A lot of things. Nikki, would you mind introducing yourself a little bit, and then could you give the comment that you also talked about, the Google comment? I thought that was a really good one. I want to give you credit for it.
Well, I'm Nikki. Hi. I'm a childbirth educator at a local community hospital outside of Boston. I have a medical background and was sort of behind the scenes on labor and delivery for a year or a little over a year, and transitioned to being in front of the classroom because it was more in line with my own professional style, values, wishes, desires, where I felt that I was going to be most fulfilled professionally. And what did I write as my comment? Oh, the whole debate about we want people to take ownership for their medical decision making and choices because we live in a very litigious world. And so nobody wants to risk getting sued. So they're like, not only are you going to sign this consent form, I'm going to make sure you're making that choice to do it. On the flip side, when Joyce was saying that you have somebody who comes in with studies that supports their out of the standard choice, all of a sudden that same healthcare professional is like, don't confuse your Google search with my medical degree, which is a meme that we see floating around the internet. And being a part of groups of patient advocates and also groups of MDs, I will say that I am disheartened to admit how many times I see that floating around with lots of hearty chuckles among the medical community, which is sort of an unfair insider scoop, but like, and maybe it's, you know, not meant to be harmful, but it carries a lot of harm when you send that message out, even if you meant it as a harmless joke. And so that was just the comment I was making back about what Joyce had said with when you want to bring your own evidence for your care. Doesn't make a difference.
So clearly thank you so much for that. Clearly there's so much history behind the way many medical providers are trained and groomed themselves, the way that, you know, consumers of healthcare are trained and groomed over their lifetimes. So this is the unfortunate reality that we live in, that we have to birth in. So let's ping back to Joyce's excellent comment about what are some red flags for interactions with providers that would be showing you that they're not somebody that practices informed choice and not somebody that practices shared decision making. Because what I will say is, even if they're the minority, even if it is difficult to find, there are providers in the state of Massachusetts and around the country that practice informed choice and a shared decision making model of care. So Joyce, any personal experiences you can share that shed light on this?
There's a little part of me that says, own it. You know, go, if you don't need to please your provider, right? If you go to the worst provider on the planet and I don't know, they're horrible human beings and they call you names or something, yeah, don't go to them again. If you're getting the standard care and it fits your lifestyle, fine, right? Fine. Okay. It's your body. It's your choice. If you're not getting the information that you want, find it somewhere else. If you want more dialogue and you want a different style and you're wanting a deeper relationship prenatally with a prenatal care provider, yes, there are some really amazing prenatal care providers in all over Massachusetts. But maybe what we're looking for in our prenatal care provider is not possible in our insurance time frame, number of patients, how many people we can see. Maybe it's not possible. And maybe that's not the place to get the information that you want and need. Maybe it is just a business transaction. Maybe your prenatal care provider is not your source of information. It just should not be a source of contention. That should be, maybe it's just neutral. I don't know. I also haven't slept in, 36 hours. So
at a birth.
Yeah.
I hear you. I get emails from pregnant people that say things like, I can't choose my provider because my partner's in the military and I have to give birth with this particular set of providers at this particular hospital. So there's definitely that plays in. There are parts of the country where the only hospital is, the only one around, right? And there isn't a choice. But most of the people that are on this call are in the Massachusetts, New England area, and we have a lot of choices. We are not in a part of the country that is in a desert of choice when it comes to where to give birth. From my house in Millbury to Mass General in Boston, I pass with my car, right, as I used to drive into Cambridge, St. Vincent's in Worcester, UMass in Worcester, Newton Wellesley, Metro West Medical Center, Mount Auburn Hospital, Cambridge Hospital, right? Not to mention Brigham, BI, Mass General. So that's just from my house to the ocean. And it takes about an hour without traffic. So I don't know. I would say that it doesn't have to be that way. I don't know. Maybe I'm an optimist, but I feel like if your provider is, like you said, making you cry or not answering your questions or not taking your birth plan seriously, belittling you, calling you names, and I'm not being extreme because I know providers that act like that. If they are, not having a conversation when asked, because I agree that in many instances, there isn't a lot of time to have a lot of conversation. And for many people, maybe that's not something that they desire. They just want to go with what the doctor recommends or the midwife recommends, and that's perfectly fine. That's their choice. But if you then do ask a question, if you're not given good information back, that's a red flag to me. I mean, I had a provider once, this was a pediatrician that was talking to a postpartum family about putting the baby under treatment for jaundice, which is called phototherapy. And they recommended the phototherapy, and the parents had taken my childbirth class, and so they knew about the brain questions, benefits, risks, alternatives, what happens if we do nothing but so they said, well, what are the benefits and risks? And the pediatrician said, well, the benefit is that your baby won't get brain damage, and there's no documented risks. And that's like, I mean, if I was that person, I would say, well, I need to talk to another pediatrician about this, because that's a bogus answer. Like,
you know that it's a bogus answer, but they don't know that it's a bogus answer.
But I agree. But if you're listening to this podcast or videocast right now you know that is a bogus answer. And
millions of families have phototherapy for the most bogus reason. Millions of families have formula for the most bogus reason. Anyway.
But if I believe that telling people this information does nothing, then I might as well just stop doing what I do, right? I know for a fact that it can't work 100% of the time, but there are dozens and dozens and dozens of people that I have interacted with in pregnancy or in labor and birth, that me giving them information has helped them make an informed choice. So I can't live my life if, I don't continue to believe that. And I feel like I have evidence for it. So if you are listening to this videocast, podcast, and that's something that's said to you, right, then know that that's bogus. There is nothing where the risk is either death or no, you know what I'm saying? Death or no risk at all. There's nothing, not one obstetrical intervention, not one pregnancy test, not one newborn intervention where it's either death or nothing like that.
Also, there's never, ever such a thing as zero risk in anything. So if they can't come up with a risk, then they're hiding it.
I agree. I mean, for example, when I worked as an OBGYN office nurse, I would have to counsel people about genetic testing in the first trimester. And, a lot of times these are just presented as choices for the expectant parents, but with no discussion about pros and cons, right? And so one of the risks, for example, of getting genetic screening, which in the interest of full disclosure, I got, cell-free DNA genetic screening with my pregnancy. But the risk is that you will get a false positive that can give you a lot of stress, that then you go on and feel outside pressure or inside pressure to get further, more invasive tests to then find out that everything was normal to begin with. Another risk is that you find out something that is true and also bad news, And then you have to know that for the rest of your pregnancy. Some people want that, some people don't. And so that is a risk. But saying there's no risk to the test because it's just a blood draw, so there's no like hemorrhage, infection, that type of like medical risk. Yeah, there's not a medical risk to getting a blood sample or a cheek swab, right? Meaning like, you know, diarrhea, headaches, those kinds of like side effects. But there are risks to getting tests. And sometimes that's false positives. And sometimes that's knowing bad news, right? So thank you, Nikki, because if someone says there is no risk, that is never true. It might be that there is a risk and it's a risk you're willing to take, as is your right. But
can we talk about Allie and Leah because home birth came up, right? So I'm going to be a little flippant, right? So what I'm going to say is you don't go to an obstetrician to talk about home birth because they don't do home birth. You don't need anybody's permission. I wouldn't even dialogue about it. The American College of Obstetrics and Gynecology says the safest place to have your baby is the hospital or birth center. Do not have a home birth. So don't ask permission for something from someone who doesn't do that service. It's like asking your car mechanic about birth. Anyway, but backup plans in terms like in here in Massachusetts, it's so amazing. As Melissa was saying, we have a bajillion hospitals, a bajillion maternity care providers. You do not need to have a relationship with an obstetrician gynecologist or a hospital-based provider to have a home birth. If we need to transfer from a home birth to a hospital at any point during pregnancy, birth or postpartum, we have plans for that. Like we develop a closest hospital, I've been in labor for 4 days and want an epidural hospital. And we are received very well. We have some of the best home birth midwives in Massachusetts have the best neonatal and maternal mortality and morbidity statistics of all the practices. We are well respected. Most of us have really great relationships with our local hospitals. So you don't need to get permission from a hospital or develop a relationship or, in the old days, right, in the movies, you'd call your local doc and you'd be like, I'm in labor, meet me at the hospital. And they would drive to the hospital and bring in their brown bag and catch your baby. And it just doesn't work like that anymore. Every American woman now, or a birthing person, walks into the hospital and you get who you get. And we get who we get if we need to transfer. But again, we have this really great relationship. We have some transfer protocols. We call in ahead of time. We do SBAR and all that other stuff. So I would encourage you not to talk to your obstetrician about home birth. Call any home birth midwife on the massmidwives.org website.
And just to add to that, I went through this with my second baby and have some friends who are OBs, and it's almost like they almost can't know that you are planning that, right, because that puts them at risk. Right. That if they know you're planning that, if something goes wrong and then you sue them, which most OBs, from what I hear, are sued at least once or twice in their career, which is horrible. And because most of them have well-meaning intentions, right. They want everybody to be okay, but they're not trained in home birth. They don't know who your midwives are. And maybe even if they do, they don't know every little thing about their practice. They're not allowed under their malpractice insurance to almost bless that in a way. So it's not that we're trying to say like, oh, don't ask them because they won't support you. They might, but they're kind of in a tough spot where they can't do that. Because I was able to find a couple OBs, actually 3 of them, when I was pregnant years ago, and I told them what I was hoping for, and they said, okay, well, I can't take care of you then, but here's the people you can talk to, which was lovely, that they gave me that information. So it was...
Right, and it's different places. In Western Mass, there's some great relationships with a couple of hospitals, Cooley Dickinson and Bay State Greenfield, where patients see the hospital care providers 3 times and have home births, and there's a very congenial relationship, and everybody likes that. In Central Mass, we're kind of populated with UMass Memorial, and they say, don't ask, don't tell me. Like, you can come see me and you can get prenatal care from me, but I don't want to know. We transfer very well into the UMass system. We transfer very well into the St. B's system. But they're not interested in receiving our records or knowing about people who are having home births. And in Boston, Mount Auburn has a relationship with some of the with home birth midwives, where sometimes they'll do co-care, not silent co-care, not like under the table, but like they'll do 5 appointments. But BI and Brigham and Mass General and Tufts, they just say, yeah, if you need to come, because there's 50 providers and you're just literally going to get who you get. You don't need to be in the system to be seen by that care system. Yeah.
Allie had a good question that I think we're kind of talking about, and she said, I'm considering a home birth, but I'm unsure how to develop a backup plan while including my current midwife at MGH. So what I would add to what's already been said, which is excellent, is that's something that when you hire your home birth midwife, they're going to talk to you about in detail, right? So when I had, in the interest of full disclosure, I had a home birth for my third, I sat down with my midwife, Mary Ann, and we went over, okay, if I had to transfer emergently for an obstetric reason, this is the hospital that I would go to. If I had to transfer for a pediatric issue, I was going to go to the tertiary care center near me because they had a level 3 NICU. But if I was going to transfer for a non-emergent reason, like let's say I just decided I wanted an epidural or whatnot, labor is going on too long, I was going to drive all the way to Cambridge and go to the midwives that I had started my care with there. They didn't know that I was planning a home birth, but the way it works at most hospitals is if you come into the emergency room without having established any care with any provider there, you will get the doctor that's on call. Because there's a doctor per day that, if a GYN patient or an OB patient comes in without any care or without a provider, they're the ones that are assigned to you. If you even have had one appointment, though, with somebody, even if it's an initial obstetric appointment, then sometimes they can funnel you into that service as well. So that's all of those things are going to be discussed with your home birth provider. Some of them have good relationships or, certain types of relationships with hospitals. Sometimes they don't, depending on where you are, but that's going to be discussed in detail. And Nikki made a good point. It's also worth knowing that your healthcare giver can fire you as their patient with 30 days notice and a reasonable referral to someone else who can provide equivalent care. So be careful discussing home birth if you feel that they are the alternative you would be most happy with. So I think that, you're not required to tell anybody that you're seeking guidance from a home birth provider, especially since in the state of Massachusetts, at least, this is not something that is covered by insurance most of the time. So it's not like you're double dipping. For example, I did continue to see my hospital-based midwifery team for certain appointments throughout my pregnancy. It was easier for me to get my ultrasounds and lab work that way. But I was also paying for my home birth midwife out of pocket. I didn't need to tell anybody that I was seeing her. I could pay anybody to do anything that I want, right? So it's not like I was double dipping. My insurance wasn't billing both for the same thing is what I'm getting at. And I know some insurances might cover parts, but I wasn't obligated to tell anybody that I was also getting guidance from my home birth midwife or my chiropractor or anybody else.
Can we move to choices in childbirth with actual birth? Because I want to talk about the hot button ones that are like being induced and skin to skin and delayed cord clamping. But I also want to talk about choice as in you don't have to give birth on the bed and what that looks like. Or what if you took the monitors off your belly? Or what if you pulled your IV out? Or what if you were on hands and knees? No, what if you purposely took your IV out? What if you were on your hands and knees and they wanted to turn you over a lot because they're used to women being on their back? So I know we can talk about the choices that everybody knows about: delayed cord clamping, skin to skin, immediate breastfeeding. In the past, we talked about how many support people you can have. There's lots and lots and lots of rules in the hospital. And so how do you get informed choice for your birth experience?
Can I just say, I think one of the things that I know all three of us as childbirth educators are passionate about is for people to take a good quality, ideally, independent sometimes is a good buzzword, but there are some non-independent, meaning they work for a hospital, childbirth educators who do tell you the evidence and the truth and all about your options and choices and decision sharing. But that's only one way. You know, I talk about that in my childbirth class, some of the topics you just brought out, but there's also a lot to learn. And so there are people that I've seen, and I caution against this, where they say, well, I'm just going to do whatever my doctor tells me to. And that may be wonderful. You may luck out and all the stars align and everything's perfect, but you're not going to know what your choices are if you don't even understand what that intervention is, right?
Childbirth ed is key for me. I know I am a childbirth educator, so I am very biased, but it have to, like,
I
you
think
don't have any choices if you don't know that they're there.
I think you can't understand how pervasive the follow along system is when you go into labor, and you're in labor. Like, you know, I'm the loudest, strongest advocate for so many things, but when there is a baby head coming out of my body, I cannot advocate. And you would be blown away, right? We have the biggest oxytocin rush. You will follow the chucks. Wherever there's a chucks, you're going to put your body on it. They'll just, you know, like, we're just going to check you, and you'll just get a vaginal exam, and we're just going to give you some medicine that will stop you from bleeding post-birth, and you will get an IV. Like, the lack of informed choice during birth is astounding. And you will have a baby in a hospital and go, you'll feel complicit in your own event, because I had a unmedicated home birth with my second baby in 2.5 hours, and I was pissed about it because I was mad at myself that I could not say the words, "Don't touch my perineum." I was so angry. I was pissed at my midwife first, and then I was pissed at myself. You will walk away from your birth like, I could not articulate words because there was a baby head coming out of my vagina or out of your abdomen. And so how do we not damage birthing people, right? How do we not set them up so that when they reflect back on their birth experience, they're not like, why didn't I had all this information, I took all these classes, but I still turned over, I still pulled my knees back, my pubic bone still hurts, and that IV really hurt, and I couldn't say, take the IV out. I couldn't say no. Women feel raped. They feel assaulted from words and physicality. So how do we how do we let them know? I don't, yeah. And Karen was saying that her dad was a really good advocate, and I think that partners can be a really good advocate. I've watched a father, you know, like, everybody in the room knew that we were going to do delayed cord clamping, and like the 4th year chief resident walks in and is like, we're going to cut the cord, and the partner was like, no, we're not. And the chief resident said, in this hospital, we cut the cord right away. And the partner was like, I don't care what you do in this hospital, we're not cutting the cord. And they didn't. Like, I don't think that parents realize something will happen during labor that you are not expecting. And you're going to have to roll with it and really have a lot of dialogue with whoever your support person is so that you're on the same wavelength. Because so many support people are like, oh my God, she's in a tremendous amount of pain, save her, do whatever they say. And yeah, so there needs to be a lot of education and a lot of dialogue, but I don't know how to help people not feel rooked when they reflect on their birth experience.
Oh, I agree. And I think that what you're saying, that you go to another place, you kind of,
Yeah.
you know, when you're in labor land, we call it, and it's hard to advocate for yourself when you're in pain, when you're trying to stay in the zone, when a human being is coming out of your vagina. Yeah, that is really hard to do. So that's why this has been allowed. This is so pervasive, right? Like that's a big part of the reason, is that because of the state that you're in labor. So you bring up a great point, which is birthing people have to not only educate themselves, but surround themselves by people who have been educated in ways to advocate for them. One way to do that is childbirth class, and an independent childbirth class, meaning not attached to a hospital, like Babies in Common, is a great way to know that you're childbirth ed provider isn't, what's the word I'm looking for? Like, when you
Part of the
can't,
system.
Affiliated.
Yeah, not affiliated.
yeah, well, but like you
There-
can't, like,
sometimes what happens in hospital childbirth classes, even childbirth educators now there are some awesome, and there are sometimes childbirth educators in a hospital that do feel free to say the reality, the facts, and the evidence and the choices. So that does exist.
yeah,
But-
I mean, so I teach for Babies in Common, but I also teach for
Right.
2 other hospitals in Massachusetts. And I feel like, and I know Nikki also is an excellent childbirth educator at a hospital in Boston. And I know that our classes both talk a lot about informed choice and risk benefits and all, but there are certain things that I have to just kind of wink and nod my head about, right? So my hands are even tied to some degree, less than most other places, but to some degree. So if you've taken a childbirth class that did not talk at all about choices in childbirth, then you need to seek out another class. Maybe that class had merit because it talked to you about what to expect in the hospital that you're planning on giving birth at, but know that you should continue your learning in some way, shape, or form, and find another class to that is not affiliated with that institution to help you learn more about your choice in childbirth. Another thing is what Rebecca Decker from Evidence-Based Birth talks about is, she calls it the golden ticket, right? And I love this phrasing of it, but it's something that we've all talked about for a long time. The golden ticket to Rebecca Decker, and I highly recommend her book, Babies Are Not Pizzas, and her website, evidencebasedbirth.com, to learn more about choices in childbirth and the research behind it. But she says the golden ticket is having a provider and a hospital that have the bedside presence and the statistics to back up the birth that you want, right? That's the golden ticket. Going to someone and to some place that already does what you want. Some people have the golden ticket, right? Whether it's a home birth provider or a hospital-based OB or midwife that, you know, the statistics back it up, that, yeah, they don't just do C-section willy-nilly. You know, their C-section rate is 16% for a primary cesarean, as opposed to 35% for a primary cesarean, right? So if you have the golden ticket, awesome. I'm not saying that that guarantees you a positive birth experience, because even if you feel 100% supported in everything that you want, nobody can predict what happens in birth, and nobody can guarantee you a good outcome in anything, right? But you can take a breath and know that you're probably not going to have to advocate that much for what you want. But if you don't have the golden ticket, most people don't, right? Then you're going to have to take childbirth class. You're going to have to make sure your partner takes childbirth class. You might want to consider hiring a doula that can help you decode the coded language that you hear in labor and delivery a lot, right? That you might not necessarily know that you're getting rooked when you hear, but that doula can say, oh, by the way, when the provider said this, they meant this. They're not speaking for you, but they can help you find your voice. So I think that, because the reality is it can't, and I'm a home birth mama and a home birth supporter and a choice supporter, but home birth isn't the best option for everybody. Let's say we had the perfect scenario. Let's say that we had ample home birth providers and insurance covered it in full, and it was seamless transition between home birth and hospital birth. Let's say we had the perfect system. There are still some women that just would not be able to have a safe birth at home, right? They need hospital-based care. They still deserve good, informed decision-making, trauma-informed, informed choice, compassionate, family-centered care. So, it can't just be home birth, because that's not the best choice for some people. And some people want, for example, an epidural, which you can't get at home. That's what would give them a positive experience. So hospital it is then. Jeanette.
I think it's also important to think about, like right now in the middle of COVID-19, partners are even more relied upon for all the support, all the information, making sure that your partner knows all this stuff and has been paying attention and reading the same stuff you're reading and watching the same stuff you're watching and really putting it in their head. Like, you need to be this person for me, which still can't save you from anything, but at least they can be your advocate because they're not the one in labor land at the time or under that intense physical situation. But also, because of what's going on with the pandemic, when you show up at a hospital, if your partner has a fever, they can't come in with you. So I really am trying to get everybody to know you need to have a second person with you who does not have a fever so that they can go in with you. So it's almost like we have to, and that could be your doula, which would be amazing. So hire a doula, have them meet you at the hospital just in case there's a fever issue, right? So they can go in with you, but then hire your doula to be on FaceTime or on Zoom with you while you're in labor and on the phone, giving you tips, having talk with you. So say, oh, what's going on now? But it's really, really key to make sure you're going to have that support, because not everybody's eligible just because you're thinking, oh, well, I'd rather have my baby at home now, which is one of the questions, like, is there more interest in home or out of hospital birth because of COVID-19? I know some midwives that are saying they're seeing that, but that's not the answer for everybody. So you need to prepare for having a support person who doesn't have a fever with you in your labor, no matter where you give birth.
And you can have a crappy home birth and you can have a marvelous home birth, and you can have a crappy hospital birth and you can have a marvelous hospital birth.
Right.
You are more likely to have a marvelous home birth.
I always say it's very difficult to find someone who had a successful home birth that didn't like it.
Right. Right.
Yeah, I had a wonderful hospital birth with my first. The labor wasn't wonderful. It was god awful, 36 hours of back labor, but the care that I received was wonderful. Wonderful care.
You chose to have a doula.
I chose to have a doula. Yeah, even though I was a labor and delivery nurse, birthing at the hospital that I was working at, had my pick of any nurse and midwife that I wanted to take care of me, a partner who had been married to someone who talks about boobs and vaginas all day, and a mom who'd had 4 vaginal deliveries herself. I still had a doula. It's valuable. It's valuable in more ways than I can even say.
So some strategies, right? Like you need you need to be respected, cared about, listened to, and I say loved. Whatever. That's my hippy dippy part coming out. When someone is disrespectful to you in labor, remind yourself it's not about you. Like I try to remind folks that you will get treated however the hospital births have been going down for the last 10 days. If they had, 4 10-pound babies come out vaginally unmedicated, they're going to be like, oh, cool. If they had fetal demises recently, that everybody's on high alert, you get the most conservative treatment. Unfortunately, it's not about you. This experience is the most amazing experience of your life, life-changing, but you are in a system that is coping with up to 25 births in a 24-hour period. So if someone is like slamming the door, not closing the little privacy curtain, doesn't knock, you get to say, you got to knock, you got to introduce yourself, or your partner can say that. But remember that it is not about you. They are not like, they don't hate you. They literally are just going from room to room to room, caring, well, not with COVID, but they're caring for a lot of people. And somebody out in the front desk just gave them 14 more things to do. And so they didn't knock when they came in. Don't take them personally. And when you don't take them personally, you don't care about being a compliant patient, right? And if you want to take the monitors off, you take the monitors off. And if they come in and they admonish you for that, you're like, oh, well, they weren't comfortable. Whatever, like own it. It's yours. And don't take anybody else's desires or admonishments personally. Like I'm trying to figure out how to strategize so that you don't walk out of your birth experience feeling like I got rooked and the people that were around me didn't like me and I didn't like what they did. Do you know what I mean? Like how do you
two things I would say about that I'm always saying in classes is always request the nurse who loves natural childbirth. And it sounds silly, but it's super true. Even if you want an epidural, even if you're going in for a planned C-section, because that is the chick like Melissa who knows that she has spent her own time and money to go to conferences, to read books, to see films, whatever it is, for her to learn how to give more encompassing care. and all the creative things to do. And all the nurses that work with that person know who she is. And that's going to go a long way to help you getting the care you want. Second of all, if you get somebody, whether it's a nurse, midwife, doctor, who isn't treating you that way, or you're feeling a little off, or maybe they just smell like smoke and that's bothering you, you absolutely can have your partner, or if you're feeling up to it yourself, say, hey, can we switch out? Like, can we have somebody else take care of us? And that sometimes is possible. Sometimes it's not, but at least you're making that effort. And I've witnessed that as a doula where they've made that happen to get a different nurse to take care of them. And I know I've heard a recent story where a client of mine was able to get a different care provider to come and take care. She literally told me the story that she literally said, I don't ever want to see, it was actually a midwife. There was a midwife she was working with who she didn't know, but she didn't like the stuff the midwife was saying. And she said, I don't like that midwife. I don't want to see her in my room again. And then an OB came in and she liked what the OB happened to say. She'd never met that person before, but whatever the OB was doing, she appreciated that care more. And so that was really helpful that she knew she could do that.
Absolutely. Yeah, I also, and I've gotten some pushback for saying this in the past, but I stand by it. There's an element of playing the game where, you catch more flies with honey than vinegar. And if you get a nurse that when they come in the room, especially, the partner, because the mom is in labor, is, hi, how are you? I'm Brian. What's your name? Have you been working here long? Do you have any children? Where do you live? Are you a, Red Sox fan or Patriots fan, right? Like, if you schmooze the nurse a little bit, and I wish that this wasn't the case, but we are all human beings. It just changes the whole feel of the room, right? I mean, I do this anyway when I go in to meet new parents, because I want to change the whole feeling of the room to being friendly and warm and inviting. But that's me, because I'm an extrovert and I love to chit chat. But if you, humanize yourself with that nurse, your care is going to be better. And
Melissa, I'm going to be an asshole.
I know you shouldn't have to do that, but
I'm going to be an asshole and say this. I agree. I have never gotten thrown out of a labor room. Most birthing people are women. We have been enculturated to tend and befriend and to go along to get along. But what I have been seeing is women will accept small abuses in the labor delivery room in order to get their big stuff, right? So if they can make nice with their nurse provider, whoever is in the room at that time, and consent to monitoring or an IV or whatever, a small thing, then maybe those providers won't take their baby off and will do skin to skin. Or maybe if they can engender compassion to a care provider, to a nurse, that nurse will help them get delayed cord clamping. I mean, we are asking a woman to have a baby and then to work the room, I'm gonna swear, to work the fucking room to get what she wants. I agree with you, and I work the room 6 ways to Sunday, but I'm still furious about it.
I'm not saying you shouldn't be furious about it. I'm furious about it.
Yeah.
I have to work the room. I have to work the room.
I totally work the room.
I shouldn't have to do that. I should be able to be treated like a professional that I am. I'm a nursing professional with my own scope of experience and expertise. But I have to say things a certain way to get what I need from my patients. I'm not saying it doesn't infuriate me. It does. But at the end of the day, right?
Yeah, totally.
How I want people to have positive and empowering birth experiences. I got to give you tools. And one of those tools is playing the game. That's the reality. And if you don't want to play the game, here's the best part.
Yeah.
You don't have to, but it might mean that you go to a home birth, right? Yeah. Or you drive 2 hours to get to a hospital that is going to give you the compassionate, shared decision-making type of care that you deserve, that everybody deserves. I'm speaking truth. The truth is that's not the standard of care at most places. And if that's something that you desire, these are your options, right? Play the game, drive and find, even if it's super, super inconvenient. And I hear that a lot too. I really don't like my provider. I know that, they're not treating me and taking consideration for my birth in the way that I want. but their office is right next to where I work. And hey, that's fine. Like I did that for my second delivery. I absolutely did. I had already had a baby. It was incredibly difficult to get from Millbury to Cambridge to see the midwives that I loved. And, I had talked to Jeanette many times about, the provider that I had chose. I chose the best doctor that I knew in the area that was going to provide the best care that I desired. But that provider went in when I had my baby, and the hospital that I ended up at, that I chose to deliver at, I had to play the game. I had to consent to things that I knew were not evidence-based so that I could get the things that I wanted. But I also have to own that decision, because I knew that I didn't have to do that. I knew that I could have driven, as inconvenient as it was, to Cambridge for all of my prenatal appointments to get the care that I knew I could get. So, hey, lesson learned, and my third was a home birth. But that's what people have to understand. It sucks to play the game. It shouldn't be the case, but I can't change the whole system overnight. I
get it. No,
so,
practice saying no thank you. Practice saying give me my baby. Get great prenatal care with someone who you really like, and empower your partner to speak for you, because you're not. It's unlikely to be able to speak when you're having a baby.
But also remember to say thank you. Maybe not in the midst of labor. I don't want to put pressure on anybody to do that. But if you do receive that kind of a care that does make you feel empowered, makes you feel like you made your decisions, and even if you end up having a C-section that you didn't want, but it was an enjoyable enough experience, and you can tell that the care providers tried to make it as good as it could be for you based on what you wanted, then make sure you thank them for that. Make sure you post about that. Make sure you share that with people, because that's what we need to know, is who are the providers out there, because they're out there. The other thing I wanted to say related to earlier in our conversation, but it's gone through the whole thread, is that the standard of care differs between provider, differs between practices, differs between hospitals, differs between states and countries. Like, not just because someone says to you, well, this is the standard of care here, or this is a policy, that doesn't mean that's the same everywhere else. Whether they're doing the same gestational diabetes testing or group B strep procedures in another country, that even vastly differs. And they're all looking at the same evidence, but making different decisions based on that evidence. So that's fascinating to me too. So it's more and more important to get that information so you can get to a place where once you're in labor, whether you have a labor or not, once you're at your baby's birth, that you don't have to think about all of that, but you still need that partner or someone else there as your advocate to be kind of watching over and asking the right questions, or maybe just to say, oh my gosh, they would feel so much better if they had a pillow pushed in right there. Like, sometimes it's a little thing that can make or break your experience. Like, oh, my neck was killing me. Well, if you had a doula, you might have known, the doula might have known to put a pillow right there. Sometimes it's little things. On that note,
I was going to say, before we end, because this has been a really awesome conversation, is there anybody else that has any last comments or questions for Joyce or anybody? Yeah, Nikki?
You have to unmute.
Oh, you got to unmute. There we go.
Yeah, no. So I was thinking about this as we were talking about childbirth ed classes and community-based classes, which I am like all for, and I love. I've seen Jeanette's class. I've seen a lot of my colleagues' community-based classes, and I will say that there is also a lot of dangerous information out in the world that it's a small percentage, but it can encourage expectant families. Like, it creates a divide that is on the other side. Not that you should just go along with whatever your doctor says, but it should be like, you should not do anything that they want to do to you. It's all bullshit. And that is equally, if not more dangerous, at least equally dangerous. And I am very conscientious of that, as having been on the other side for a short time, that it is extremely hard for a really awesome OB or midwife or labor delivery nurse to take care of a person who is not using any critical thinking or logic or understanding, because they are so combative to the other side, because they're so fear driven and they're so determined that they're not going to have any problems. And so I would just caution everyone, with all of this conversation we've already had,
that there's also some bad information out there in the world that you should not follow just because it sounds like the opposite of things we've just talked about, because it's not. That's not, there's this middle ground where people can actually have, coming back to the beginning, shared decision making in care.
Right.
To tag onto that, yeah, exactly. And sometimes all of the interventions are really what you need. Mm-hmm. And those are what are really going to help you have a good outcome and a good experience too. Just because you wanted a home birth and you end up with an epidural and then you end up in the operating room, that can still be like, wow, I'm so glad I was able to have all that expertise of those providers around me because I needed all those things. Or maybe you didn't need all those things. They didn't happen to you, but at least you were in a place where you could have had them if you needed them. There's so many different variations, so definitely agree.
Right. It's about the respect and the caring and the listening, and not necessarily the method with how your baby comes out. It's not about these things are bad and these things are good. It's the relationship building and the trust and the respect and the listening. I 100% agree, Nikki, 100%.
If you are a pregnant person or will one day be for the first time or again, I think a great take-home message is that you matter, your choices matter, and you deserve to be treated compassionately and be part of the decision-making. And if that's something you desire and that's not something that you are getting, know that there's information out there to help you find a provider who will respect what you deserve.
So read Millie Hill's book, and then
Yes.
I'm sure Jeanette has I have a very simple choices in childbirth checklist 1-pager, mostly as a dialogue between the birthing person and the partner, just to start the conversation, and so that those two people who are going to be at this birth are on the same page. So there's lots of tools to support your desires. And we all want to be respected, cared about, and listened to and loved. I work with people who plan C-sections. Again, it's not about the procedures, it's how you're treated. It's how you're treated.
Is that something, Joyce, we can put in the show notes?
Sure. Yeah.
Awesome. All right, so we can do that. Any last thoughts, Jeanette?
I'm sure, I know for a fact, because I know Melissa and Joyce so well, and Nikki as well, there are situations that we have been in births with people that we're working with where we have seen care providers be so respectful and so lovely, from an obstetrician, midwife, nurse, whatever it is, be lovely, even in the face of a scary thing or in the face of, I know you really didn't want this, but here's what's going on. This is why we need it. And we've also seen care providers be horrible and mean and evil, and to the point where you're like, I can't believe they just said that, and I'm here as the doula and I'm just witnessing with my mouth shut, and I can't believe I just heard them say that out of their mouth. You're just like, wow. So there's both, but I know that a lot of this conversation comes around to feel very negative, and because that's the reality. But it is possible to have that, stars aligned and that golden ticket. But absolutely, it's a matter of making sure that you and someone else are really investigating that. And it sucks that it has to be put on the birthing person to try to find that. You're right, Joyce. That's not okay. And we're hoping that birth will change in every culture over time, but it starts with each individual, unfortunately. So, but thank you, Joyce, so much.
Oh, thank you.
Does anybody else want to say anything?
I just wanted to make a quick comment. Like I said, I'm a student right now, so I'm going through all the online classes and everything else. But I can't wait to actually get in with the profession and just hopefully make a difference even in just a few lives.
That's awesome. Thank you, everybody, for listening today.
Who was born at 6 o'clock this morning.
Oh. All right. So
babies come out
last night.
Babies come out.
Babies come out.
Yes. All right. Well, on that note, awesome. Thanks for a good conversation. Thanks for everybody for being here and great questions and comments. And of course, thanks to Joyce for saying yes. We hope you guys will be in the future part of future episodes, or that you'll listen to them or watch them again and share them with your friends. And we are still working on the schedule for the upcoming podcast, but there's one scheduled for this Wednesday, and we'll be talking about movement and mindfulness for pregnancy and birth. And I know one of our guests that day, we have 2 guests that day, are planning, I believe, on taking us through meditation and working on that. So that'll be really different than this heavy conversation that we were having today. So you can get a different mindset.
Jeanette, will you put my email address, because I can email a link that we have of questions to ask your home birth midwife, and I can email anybody the choices in childbirth. Right. It's just a talking document that has a lot of the stuff, birth stuff.
Yep.
Yeah.
Thank you.
Email is like the best thing for me. So JoyceKimball3@gmail.com.
Yeah.
Awesome. Yes. And if you learned even one tiny nugget of helpful information today, right, please don't be stingy and text a friend who is either expecting or parenting and tell them about us. If you want to laugh your stretch pants off while learning about childbirth, babies, and breastfeeding, please consider taking a live and interactive Zoom class with Jeanette or I while you are quarantining. And virtual lactation consults and support groups are also available. And if you like us on Facebook, Babies in Common, we're always posting great articles, videos, resources to help you rock your birth and thrive as a new parent. We hope you will join us, and we are a community for you. After all, we all have
babies in common.
Jazz hands.
Bye, guys. Thank you.
Bye, everyone.
Thank you, Nikki.
Thanks, Nikki. Thanks, everybody.
Thank you, Joyce.